should feel pretty confident that I'm onto something. And I'm going to use those special tests only in instances where I really need to either confirm the presence of something, and we're going to look at clusters. That's what the evidence is telling us to do. The one test result in isolation isn't statistically significant, or we're going to look at ways to rule things out. So in the C-spine, I find that we do a lot more to confirm things with our special tests than to necessarily rule things out. Would you all agree? So we're getting through our exam. They have pain that radiates down the extremity. Maybe they have pain that radiates to the elbow. We've recognized that maybe they have pain with coughing and sneezing. There's enough signs to indicate some sort of potential nerve root involvement. So I get to the end of my subjective, and I'm already thinking some sort of nerve root impingement. Okay, I'm not thinking disc, nerve root impingement, whatever. The nerve is involved. Okay, and now I'm going to get to my exam. I'm going to look at my quadrant testing. I'm going to look at my range of motion. I'm going to look at my dermatomes, myotomes, deep tendon reflexes. We're going to re-examine upper limb tension here in a second. Okay, but I'm using all of that information, gathering as much information as possible, then finally getting to special tests. And if I'm looking for cervical redic, that's where I use these. Okay, and I use a combination of foraminal compression, distraction, and upper limb tension. You can use quadrant test. We did that. Usually I'll start there first. I'll take and I'll put their head in a quadrant position. And what am I looking for here? Okay, reproduction of symptoms. I'm not looking at their available range of motion. I'm not thinking opening versus closing. They report symptoms in their exam. I correlated them, or during the subjective, I correlated them during my exam. I'm putting them in a provocative position to see if I can't increase or reproduce those symptoms. Okay, the only purpose of the quadrant test here. You can use it in other ways. Okay, so cervical rotation, side bending, extension. Trying to lock down those facets and irritate. Okay, so the ones that I predominantly utilize are Sperlings, the cervical distraction, and then upper limb tension. So Sperlings is a little bit of rotation, side bending. I'm going to close down that right facet. Okay, I usually will come in and rest my elbow right on their shoulder. Okay, you're standing behind them, and you're just applying a force in the plane of the facet. So I'm not pushing straight down, I'm pushing in that plane. And again, what am I looking for? Reproduction of symptoms. I'm not seeing how much I can cause them to break. I'm pushing pressure through the top part of his head, and I'm trying to reproduce those radicular symptoms.
On this side?
On the side that I'm testing. So for him, it would be the right side. Okay, think about what's going on here. If I put him into slight rotation, full side bending, get him here, and then I drive down through that head, I'm putting him in a closed position, right? Closing off that normal foramen on that left side, and then applying a compressive force to further load it. Okay, normally would I feel anything more than just pressure in the facet? No. So I'm looking for reproduction of those radicular symptoms.
Do you have them sit a certain way for this? Like, do you ever push on people and
You know, if they're folding down, I might put them in a supine position. You can do this test in supine, although you negate the effect of gravity.
So when you say a little rotation, you're talking about 45 degrees, was it?
But rotation, minimal, 5-10 degrees,
Okay.
full side bending. Okay, so if I was going to do this in supine, okay, rotation, side bending, okay, get here, and I just load that way. So if for some reason they really were folding up underneath the pressure because of pain, because of guarding, whatever, get them in supine. That's not the way that the test was intended to be done, but at least you can get a good feel for distraction. I can either do it sitting or supine, so don't pay attention to my body mechanics. Okay, distraction, just cradle the occiput, and it's just like doing cervical manual traction. Okay, I lean away, I usually hold that for a 5 or 10 count. What am I looking for as a positive test result? Decrease in symptoms. Okay, so I'm not looking to reproduce or increase their symptoms with that first test. I'm looking for a change or a decrease in their symptoms. Okay, in sitting. Yeah. Okay, so I can do the distraction in supine. I can also do in sitting. A lot of times I'll come in, I'll get right underneath that mastoid process, and then I'll just lift straight up. I'm taking my thumbs really. Okay, so I'm not digging into his cranium. Getting right into that external occipital protuberance, getting my thenar eminences just underneath this mastoid, and then just lifting straight up. Okay, you can just get a nice little distraction force that way. So I can do, if you look at a lot of Syriacs, he does straight compression. Sperling's is doing a lateral flexion compression, and then distraction, I can do all three of these in sitting. So just really quick screens. Questions about distraction, pyramidal compression, straight compression, or quadrant test? Okay, let's really quickly review upper limb tension. This was a pet peeve of mine again this weekend with practicing PTs and not breaking down the components of a neurodynamic assessment. Okay, I skip later. Here's important. Okay, components of, we're going to start with median nerve. Okay, this is the test that's in the prediction rule by Weiner. Okay, I'm going to start with scapular depression. Okay, what I see a lot of people do is like putting their hand on their shoulder, and I saw half of the PTs this weekend at the course I was teaching did this. Put their hand on their shoulder, got their arm up here, got them flexed, abducted, extended, like, oh, their neural tension looks really good. And then I come in, depress the shoulder, abduct, fully externally rotate, extend the wrist and the hand. About there? Yeah. That's a very different test result. Okay? So go through the components. This is a very systematic assessment. If it's done right, it can be very prognostic and diagnostic. So get that shoulder depressed. If you're having a hard time because of smaller hands or smaller frames, set it up. Get their scapula depressed, and then I put my fist down to hold that scapula in depression. He's not going to go anywhere. Okay? Look at abduction to about 110, 120 degrees, right? Okay? Full external rotation. To break these down into the components. Wrist extension, finger extension. Okay? Full supination. The last part is elbow extension. And I'm lighting him up pretty good right there. He's about 45 degrees from fully straight.
Where's on this side?
Okay, so let's look at this side. Everyone see that that's a really different result than if I just come in, do this, and I get them to there, and that's a really different result. Where I bet you we're not only going to get them to 30 degrees. Up there? Yeah. Like 30 degrees from 90. It's about 60 degrees, lacking full extension. Okay? So just break it down into the components. When you see practicing long-term practicing PTs, okay, radial nerve, I'm going to bring them into about, what, 15 degrees of abduction, shoulder extension, scapular depression, full pronation, wrist flexion, and then I'll usually just bring them into a little bit more extension. Anything there? Okay.
Can you say that one again?
Yeah.
Scapular depression.
I'll walk through the real one, the proper way. Okay, scapular depression. Okay, I bring them into abduction. Okay, elbow extension, wrist flexion. You can even bring them into finger flexion. The last thing I'll usually do is bring them into slight extension. I feel that. Okay. So let's practice those two.